All right. Well, it is 8:01 and we have more than 30 people, and I'm sure those numbers will grow, but I want to give Dr. Benson all the time that she needs. And really, she needs no introduction, and she told me I didn't have to, but I think it's always good for us to remember all of the incredible things that she's done. And I'm going to shorten it up a little bit, but I could talk about her achievements and accomplishments for the first 10 or 20 minutes of this, but I'm going to keep it shorter than that.
Please do.
So Constance Benson, Connie, is a professor of medicine, senior attending physician, and vice chair for education in the Division of Infectious Diseases and Global Public Health at UCSD. She currently is the director of the UCSD Antiviral Research Center, the principal investigator of the UCSD NIH-sponsored collaborative HIV clinical trials unit, a senior investigator in the UCSD AVRC HIV clinical research site, and serves on the executive committee of the UCSD Center for Innovative Phage Applications and Therapeutics. She also served as the UCSD Infectious Disease Training Program Director until 2021. Dr. Benson is an internationally recognized clinical investigator working in the fields of HIV, TB, non-TB, mycobacteria, and SARS-CoV-2 clinical and translational investigation. She has been involved in numerous studies, again, too many to name here. So I'm just giving the highlights here. Her own major areas of research interest include drug-resistant mycobacterium tuberculosis and non-TB mycobacterial diseases, other HIV-related opportunistic infections, new ARV drug development, the treatment of HIV infection and its complications in resource-limited international settings, and the antiviral treatment of SARS-CoV-2 infections. I mean, is there anything else that we can add on here about all of the research that you do? And I just want to highlight another thing. Dr. Benson also served as the UCSD co-director for research capacity development for the former NIH-sponsored University of Eduardo Mondlane Medical Education Partner Initiative, and leads research training efforts for the current D43 training grants with Dr. Mohammed and Dr. Schooley at UCSD. There's more. I'm gonna stop here.
I think we could stop, Jill.
When everyone knows this is Dr. Benson, let's pay attention to what she has to say because it's going to be very good. Connie, I'll keep an eye on the chat and try to only interrupt for clarification, and we'll try to save some questions for the end.
Sure, but I hopefully left enough time for interaction. So if you want to interrupt me for questions, that's fine too, because it's always difficult to do these updates when you're putting together such disparate groups of studies. So
yeah. Okay.
Don't feel shy about interrupting. So thank you, everyone, and thank Jill for that very kind introduction. And today I'm going to talk about select opportunistic infections and organ system complications from data that were presented at CROI 2022. And as you saw from the introduction, this is an ongoing series we've put together to try to keep everyone who works in these fields up to date on what was presented at recent large international conferences. So moving right along, I'm going to just briefly show you any financial disclosures that might be pertinent to you, but most of these have nothing to do with my talk today. So here's the outline of what I'll be discussing. And because Jill pointed out TB is my favorite opportunistic infection, several of the presentations focus on that. But I'll also present some data on cryptococcal meningitis, hepatitis C, human papillomavirus associated complications, and then finish with HIV associated end organ complications, primarily metabolic ones that have to do with our patient population with HIV. So let's start with opportunistic infections. And this just gives you a flavor of many of the things that were focused on related to tuberculosis at this year's CROI. The first two talks, or the first two studies I'll present, have to do with treatment of latent TB infection. And as you know, the CDC is focused on trying to identify people with latent TB infection and get them treated as part of our elimination of TB goals, similar to our elimination of HIV goals. So this first study was a multi-center pharmacokinetic study in adults who were receiving dolutegravir containing antiretroviral therapy and who were fully suppressed and had an indication for treatment of latent TB infection. The intervention studied here was daily rifapentine in a dose of 600 milligrams plus isoniazid in a dose of 300 milligrams given for 28 days in combination with dolutegravir given 50 milligrams twice daily. The goal of this study was to look at the safety and pharmacokinetics of dolutegravir in patients who were receiving daily rifapentine and isoniazid as part of the 1 HP regimen for prevention of LTBI. And as many of you know, the current CDC American Thoracic Society guidelines do not recommend 1 HP as a first-line treatment for LTBI. However, the rest of the world does, and the WHO bases their recommendation for 1 HP in people living with HIV on the 3,000 patient study that was published a couple of years ago now, studying this regimen in people living with HIV around the globe. So this is an attempt to look at what interactions might be seen with the 1 month regimen in combination with dolutegravir. So the outcome of this study in 37 patients who were enrolled, 56% of whom were African and 44% women, an interim analysis done in the first 25 patients enrolled. If you look at the bottom plots, what you can see here are the pharmacokinetics of dolutegravir given alone. Dolutegravir given alone, not in this trial, but in the Dolphin trial, which looked at dolutegravir given once daily in patients who were on a rifampin-containing regimen, and dolutegravir or rifapentine-containing regimen, and then dolutegravir given with a 3 HP regimen for treatment of LTBI in the Dolphin study. And the point to be made in this particular portion of the graph is that 158 nanograms per ml is the target for the trough concentration of dolutegravir, which has been associated with durable suppression of HIV in dolutegravir containing regimens. And the point here being that dolutegravir alone in this study given twice daily was had comparable or elevated levels to dolutegravir given in the Dolphin trial, and all levels were above the trough concentration target. In the BID dose given with once weekly or once daily rifapentine and isoniazid, you can see the levels here over time. There was an induction of dolutegravir concentrations with rifapentine, but these were relatively modest. And at 4 weeks, they were actually well above the target level of 158 nanograms per ml. So demonstrating with pharmacokinetics and viral load data and safety data that support the twice daily dose of dolutegravir when given with 1 month of rifapentine and isoniazid for treatment of latent TB infection. The second study also dealt with latent TB infection, but this time looking at a different antiretroviral drug, which is often used now internationally and in many places in the US as an alternative to dolutegravir containing regimens, and that's the combination of Darunavir and Cobicistat as a boosting agent. And this study looked at what is one of the CDC's recommended regimens for treatment of LTBI, the once weekly isoniazid and rifapentine. And following a lead-in dose of Darunavir with Cobicistat for 4 days, rifapentine and isoniazid were added in a once-weekly regimen given in a dose of 900 milligrams each of rifapentine and INH with pyridoxine. And you can see here there were 3 weekly doses given over the course of 12 weeks, or a dose given once every 4 weeks over the course of 12 weeks. So looking at Darunavir exposures, the authors of this PK study demonstrated that Darunavir exposures were decreased when combined with 3-HP. And at day 14, you can see here and here over the period of 24 hours. And when combined with 3-HP versus Darunavir Cobicistat concentrations alone. And multiple trough concentrations fell below the Darunavir EC50 for HIV. And the authors of this PK study concluded that co-administration of Darunavir with Cobicistat would not be a good idea with the 3-HP regimen for treatment of LTBI. So moving on to yet a third PK study before you all fall asleep. Yeah,
Connie, just really quickly, this was more of a general question from Nettie about anyone using 1-HP here in the United States. I thought the answer was no, but you may know a little bit better. Just in general, is anyone, the study before, is anyone using 1-HP?
Yeah, no, I think one of the problems is that the ATS CDC guidelines did not recommend it as treatment of LTBI. And part of the rationale for not recommending it was that despite the fact that it was studied in a 3,000 patient study in people with HIV, the majority of those individuals were people from high-risk endemic background countries outside of the US, and only about 20% of that population was in the US. And the CDC did not feel that those data were sufficient to make it a broad recommendation in the US. What I will tell you, however, is that after much deliberation, the OI guidelines that were just posted online and the revision of the TB chapter are now recommending 1-HP as an alternative to 3-HP and daily isoniazid for people who might want a short, ultra short course of this regimen. And I think the PK data here suggests that this is going to be safe to do with the dolutegravir containing regimens. So we may see more uptake of 1-HP with the release of the more recent guidelines.
Fabulous news. Thank you.
So hopefully this is the last of the major PK studies that I'll highlight for you related to TB. And this has to do with women who are taking dolutegravir-based antiretroviral therapy and may be in need of emergency contraception. So this again was a timely PK study that came on the heels of the earlier part of the study that looked at efavirenz-based antiretroviral therapy and levonorgestrel contraception in women with HIV. And this is now looking at dolutegravir. And I don't think we need to belabor all the different ins and outs of the multi-center parallel group PK trial design, but suffice it to say that the PK data were evaluated in premenopausal women greater than 16 years of age who did not have HIV, but were taking rifampin during continuation phases of TB therapy, and compared the PK of the levonorgestrel impact on dolutegravir-based ART in women with HIV. And 2 different doses of LNG EC were used. 3 milligrams daily, or 3 milligrams were given once in women without HIV who were taking rifampin, and 1.5 milligrams were given in women with HIV on dolutegravir who were not taking rifampin as the control arm. And again, these curves may be a little bit hard to see, but what you can see is that the rifampin and high dose LNG achieved good concentrations, both for LNG, but somewhat lower concentrations for dolutegravir, but not sufficient to require further dose modification. And so the conclusion here is that dose adjustment of emergency contraception with levonorgestrel in a dose of 3 milligrams is appropriate with rifampin when given to people who are getting TB therapy and may also be on dolutegravir. The next TB-related study is looking at the impact of statins on TB-associated inflammation. The hypothesis behind this study is that some of the longer-term complications on lung function in people who recover from TB may be a consequence of underlying inflammation, and that by administering an anti-inflammatory drug at the same time as TB treatment, one may decrease the amount of inflammatory and fibrotic consequences of people recovering from tuberculosis. So this was a phase 2b randomized clinical trial done in people with HIV who had rifampin susceptible confirmed pulmonary TB. The intervention was rosuvastatin in a dose of 10 milligrams daily versus placebo given for a duration of 8 weeks. The primary endpoint was really a more surrogate endpoint, not so much looking at inflammation, but looking at the impact of reducing inflammation on the time to sputum culture conversion, primarily in liquid cultures through midgets determination, and as a secondary endpoint on solid culture conversion. And while the study was designed to make a big splash, it didn't make much of a ripple. And you can see from these Kaplan-Meier curves that despite an anti-inflammatory effect of rosuvastatin, it had no impact on TB endpoints of culture conversion. And the data will be followed out further looking at inflammatory endpoints to see if there was any impact on longer term consequences in people who might have recovered from TB in this study. So the next study I want to highlight is following on the recent publication, which is, I think, good news for the US, is the short course regimen for treatment of drug-susceptible TB. Those of you who saw the manuscript of Study 31-5349 published in the New England Journal, you know that a short course of INH, rifapentine, moxifloxacin, and pyrazinamide given for induction over 8 weeks, and then continuation of rifapentine, moxifloxacin, and INH given for an additional course of treatment out to completion of therapy in 4 months, was non-inferior and in fact looked a little bit better than standard 4-drug therapy for drug-susceptible tuberculosis in this study. In a follow-on analysis, the investigators wanted to evaluate one of the other treatment arms of shortened therapy, isoniazid, pyrazinamide, rifapentine, and ethambutol, so excluding the moxifloxacin arm of the study, and to see what happened in a pooled analysis in individuals who got assigned to that regimen. Even though it did not overall reach non-inferiority, there may be some patients who would also benefit from short course therapy not containing moxifloxacin. So this is the flow chart for how the investigators assigned people to high risk, moderate risk, or low risk. And it was really a combination of the cycle threshold of the gene expert assessment for MTB in sputum combined with the disease extension or the extent of disease on chest x-ray being less than or greater than 50% of lung involvement and complicating comorbidities of diabetes or HIV. And patients were then segregated into high, moderate, and low risk on the basis of whether or not they had each of these factors. And just to make a complicated story simple, in people with low and moderate risk, the outcomes related to TB therapy were similar for both the moxifloxacin 4-month regimen and the ethambutol non-moxifloxacin 4-month regimen, unless you were in one of these high-risk categories. And these are just the Kaplan-Meier curves related to these findings. Overall, about 70% of patients assigned to this other short course regimen could be adequately treated with that short course regimen, but longer regimens or regimens that included moxifloxacin for a longer duration or higher doses may be needed for patients in the highest risk category of higher disease extent, more comorbidities, and higher cycle threshold for gene expert testing for MTB. And I think this is the last TB study I have to show you, is related to treatment of drug-resistant tuberculosis. This has also gotten a lot of attention in the media. We don't see a lot of drug-resistant TB in the US, but I wanted to highlight this study because there has recently been an update to the CDC treatment guidelines related to data from the one-arm study of Bedaquiline, Pretomanid, and linezolid, or the B-PAL regimen, which was approved by the FDA for treatment, but not included in previous guidelines for treatment of drug-resistant TB. And the CDC just released their update with recommendations for how to use this regimen as a short course regimen for treatment of TB. So some of you who may see people with drug-resistant TB may be interested in the outcome of this particular study. So it was designed as a randomized clinical trial, open label phase 2-3 study in patients with rifampin-resistant disease, with the Bedaquiline, Pretomanid, linezolid for 24 weeks arm being the control arm, and 2 experimental arms that attempted to look at increased response, tuberculosis response, if a 4th drug was added to the regimen. And if you recall, Bedaquiline, Pretomanid, and linezolid for 24 weeks in and of itself had a 90% response rate. So it was unlikely that we were going to see a lot better benefit, but maybe in a select number of patients, we might have seen that. So clofazimine was added to the B-PAL regimen in one arm, moxifloxacin in the other arm, and then a 4th arm was included as a control arm with the WHO standard of care for multi-drug resistant TB, which is a prolonged duration of therapy. The outcomes looked at were mostly those of the composite unfavorable outcome definition listed here of treatment failure, death, treatment discontinuation, recurrent TB, or loss to follow-up by 72 weeks after initiation of treatment. And these are the final data from the study showing that all of the B-PAL regimens actually had improved TB treatment response compared to the WHO control arm. And these just show you some of those data based on some demographic factors. But what I want to point out here is that the control arm was actually relatively high rate of unfavorable response, not generally one we expect to see with rifampin-resistant TB. So that may color the comparison with the control arm, but in each of the B-PAL regimens, there was about 10 to 25% unfavorable response, with the moxifloxacin containing regimen appearing to look the best. And just to summarize the conclusions based on these data, you can see that the efficacy of the B-PAL regimen plus moxifloxacin was better than the 4-drug regimen with clofazimine, was better than the 3-drug regimen, and markedly better than standard of care. However, there were some safety concerns. And again, you can see that the unfavorable outcome in the control arm seemed to be largely driven by adverse events, grade 3 or serious adverse events, and in addition had relatively high rates of QTc prolongation. And again, for safety purposes, the B-PAL regimen containing moxifloxacin performed was safer than the BPAL alone or the BPAL plus clofazimine, and all were safer than the standard of care regimen. So just again, concluding that Bedaquiline with Pretomanid and linezolid dose adjusted with or without clofazimine or moxifloxacin can result in safe and effective treatments for rifampin-resistant tuberculosis. And just to follow on that study, and I'm not going to go through this complex study design, I only want to point out the issue of QTC prolongation because it is a problem when considering the combinations of bedaquiline, clofazimine, and Pretomanid. And in this study in drug-resistant TB presented at CROI as well, the interactions were evaluated between the M2, which is the major metabolite of bedaquiline, and clofazimine and Pretomanid on QTC intervals. And the conclusion, without going through all the complex details of the study design, was that there was an interaction with bedaquiline and clofazimine, but it was less than additive in terms of its effect on the QTC interval. There was no interaction between Pretomanid, bedaquiline, or clofazimine in terms of QTC interval prolongation. And the individuals who did experience QTC interval prolongation, it was not sufficient to require discontinuation of the regimen for patients who received bedaquiline and clofazimine together. So that's the last of my TB studies for those of you who are bored by TB.
No one is bored. There was a question though that I got to a little bit late related to the study with Rosuvastatin.
Okay.
Katie Riggs asked, are they evaluating lung function in the study, maybe with PFTs?
Yes, so the longer term effects of the study were not presented at CROI, but the study design is meant to look at the impact on inflammatory markers. I do not think they included pulmonary function tests in the study, but here's the abstract and the presentation. It wasn't mentioned in the presentation, so I don't think they included it, but you may want to look further on the website. I will also mention that the CROI website is now open and available to anyone. And if you do a search by abstract, you can look at the webcasts and the poster presentations at your leisure if you want more details on any of these studies.
Thank you.
Okay. Now I'm going to turn to cryptococcal meningitis. We don't see cryptococcal meningitis a great deal now in the US, but still a problem for many parts of the world. This is a fairly straightforward study that was presented as a prospective single-arm evaluation of a new semi-quantitative lateral flow test for rapid detection of cryptococcal antigen. And the testing of whole blood was performed on hospitalized patients with documented newly diagnosed cryptococcal meningitis. The purpose of the study was to evaluate this semi-quantitative component to the lateral flow. As you might know, most of the lateral flow antigen tests are not quantitative and are simply a positive or a negative. And as you also know, there may be a difference in overall mortality associated with the burden of cryptococcal disease. So this attempted to use this semi-quantitative lateral flow assay and look at patients who had high titers in the assay compared with those who had low titers in the assay. And indeed, without belaboring the point, you can see that those individuals who had high titer cryptococcal antigen using this semi-quantitative assay versus low titers had a significantly higher mortality rate compared to low titer individuals, and statistically significant. Other factors that were influenced by the ability to detect in this semi-quantitative assay low or high titers were median CSF fungal burden and median age. Older age, CD4 did not have an impact on titers, nor did it have an impact on mortality, but median CD4 count and CSF fungal burden also were associated with an impact with high and low risk characteristics based on the semi-quantitative titers. So this is yet another tool that we can use to prognosticate who's at high risk for mortality and may be a candidate for more intensive management of cryptococcal meningitis acutely. The next study I want to look at is a hepatitis C study. And this study was based on the findings and recommendations in people who do not have HIV infection, who have failed previous direct-acting antivirals for hepatitis C. And the current recommendations are that a combination of sofosbuvir, forgive me if I screw up the pronunciations, but velpatasvir and voxileprevir, the 3-drug combination, which is currently available as a fixed dose combination given once daily, is recommended in people without HIV infection, but has not been studied as a rescue therapy in people with HIV and hepatitis C co-infection. And so this was a cohort study performed in Madrid in people with HIV and HCV co-infection, and looking at this 3-drug fixed dose combination given once daily in people with HIV who had failed a prior regimen for treatment of hepatitis C. And the major outcome was SVR after 12 weeks of treatment. And here is the age group, the gender distribution, and the genotype and fibrosis distribution. And you can see most of these individuals were genotype 1A, but a pretty good representation of other hepatitis C genotypes. And most had highly detectable HCV RNA levels, and most had fibrosis category 0 or 1, liver disease, but a good representation of higher levels of fibrosis. And overall, the sustained virologic response after 12 weeks after the end of treatment was greater than 90% in the patients who did not have cirrhosis versus those who did. And there were no significant differences across treatment arms based on cirrhosis or no cirrhosis, intent to treat, or per protocol analyses. There were also only modest differences based on genotype, with those individuals having genotype 3, 4, or 1A having particularly good sustained virologic responses in the per protocol analyses. So suggesting that this regimen too should be a recommendation as a rescue therapy for people who failed previous regimens for treatment of hepatitis C. And then the last OI study that got a great deal of attention at CROI was the ANCHOR study. And this was a long-awaited clinical trial evaluating screening and treatment for high-grade squamous epithelial lesions in people with HIV infection. The study set out to evaluate 2 main specific aims, although there were others. And the first was to determine if treatment of anal high-grade squamous epithelial lesions, or HSIL, was effective in reducing anal cancer in people with HIV versus, and also to determine the safety of treatment for anal HSIL. The study was planned to enroll about 5,500 individuals who were to be randomized 1-to-1 to immediate treatment after screening for HSIL or active monitoring of HSIL lesions over time with periodic biopsies based on the schema you see here. So all patients underwent a screening high-resolution anoscopy, and anal swabs were also collected for cytology. If HSIL was found, patients were enrolled and randomized. If there was no HSIL found, they were not enrolled, and if cancer was found, they exited the study. So patients were then randomized. If they to either active monitoring or immediate treatment of HSIL lesions, and then followed for evaluation of anal cancers. This was an event-driven analysis that had 90% power to determine a difference between these two approaches based on the accumulation of up to 31 anal cancers. This is just a treatment algorithm that is an example of patients who were randomized to the treatment arm could receive initial therapy with a variety of regimens, but were asked to be treated with the same regimen if possible throughout their course of follow-up. So if they had HSIL, as an example of a treatment algorithm would have been electrocautery, all visible lesions, and then returning for follow-up visits every 6 months. Lesions that were seen were biopsied before treatment. If they had recurrent lesions, they would be retreated and continued with the same modality over a 6-month period. So these are some of the study results. Baseline demographics showed that the population had a median age overall of about 51 years, long duration of prior HIV infection. 80% were male, 16% female, and 4% were transgender. Large proportion were people of color, Black or Hispanic, and lesser proportion were white, and about a third were current smokers. 82% were fully suppressed on antiretroviral therapy, and the median CD4 count across treatment arms was about 600. And about half of the individuals had had a nadir CD4 count of under 200 prior to initiating antiretroviral therapy. One of the factors that were also evaluated was the impact of the HSIL size at screening. And this is just to say that about 80% of individuals enrolled in the study had less than 50% of their anal canal or perianal region involved with HSIL lesions. And there were no significant differences between any of the treatment arms with respect to demographic factors. The initial treatment was electrocautery ablation, also infrared coagulation, thermoablation, topical 5-FU, and topical imiquimod were used in a handful of patients. And overall, throughout the study course in the treatment arm, 86% of individuals stayed on their initial modality, with a small proportion receiving 2 or more different modalities. Overall, more than 10,000 people with HIV were screened with HRA. 52% had anal HSIL at screening, and a fairly high proportion of both men, women, and transgender individuals. And interestingly, 17 patients had anal cancer at screening without having previous evidence of that, with an overall incidence rate of 160, or prevalence rate of 160 per 100,000 population. The DSMB was notified when 32 cancers were accumulated during the course of follow-up, and the analyses that are shown here are based on the first 30 cases. 9 participants were diagnosed with invasive anal cancer in the immediate treatment arm versus 21 in the active monitoring arm, with an overall cancer incidence in the treatment arm of 173 per 100,000 person years of follow-up compared to 402 per 100,000 person years of follow-up in the active monitoring arm. The median follow-up was a little over 2 years, and the approach used in this study was associated with a 57% reduction in anal cancer incidence. And as you can see, the time to anal cancer diagnosis here in the active monitoring arm and the immediate treatment arm. There were study-related adverse events in 43 patients in the treatment arm compared to 7 in the active monitoring arm. And as you would expect, most were related to pain, infection, or ulceration from the modalities used for treatment. This study was stopped by the DSMB, and the implications based on the study team's conclusion was that early treatment of HSIL lesions was highly effective in preventing progression to anal cancer. that screening and treatment should become standard of care. And while there was a 57% reduction in anal cancer, there's a lot of room for improvement in screening algorithms, the need for scaling up of HRA, what is the role of anal cytology here, and biomarkers of progression and treatment modalities remain to be elucidated by further data from this study. I'm going to spend the last few minutes.
Connie, I will just say there were a couple of questions about this study, but I also want people to know that Lalo Kachai is going to be talking about, and I'll let Connie catch her breath, maybe have a sip of water. He's going to be presenting on this at the end of May, so I don't want to spend too much time on it. I'm really glad we got the highlights, but maybe that's just the good warm up to it, and we can maybe talk about it at the end. I just wanted to let people know about that.
Yeah. And I think that would be appropriate. I don't want to take any more of Lalo's time and effort that he'll be putting into it. This was just a quick run through, and I'm sure he'll have much more detail on the conduct of the study and the implications for some of those remaining questions that I talked about. So at the end, if there are questions related to just what I did present, I'm happy to answer those. So the next topic I want to go on to is really related to fatty liver disease. And this is another area that Lalo has been working on as well and may have thoughts. The first of these was taking advantage of an observational cohort study in a subset of individuals who are participating in the multi-center AIDS cohort study, ongoing for many years now. This subset of individuals had serial abdominal CT scans performed and were followed for incident non-alcoholic fatty liver disease over time. Demographics are indicated here: relatively high median CD4 count, a good representation of people of color, a substantial proportion of whom had comorbidities, obesity, diabetes, hypertension, and among those with HIV, 55% were on integrase inhibitor therapy and 67% had prior TAF exposure. So just giving you an idea about the incidence of those two drugs relative to weight gain and fatty liver. So 175 men with HIV and 95 men without HIV were compared for incident NAFLD, and overall 11% developed fatty liver disease over the course of the study, with an incidence rate of 2.5 per 100 person years of follow-up. The rate was higher in those who entered the follow-up period with a BMI greater than 30 kilograms per meter squared during their first scan. I just want to show you a few data from the multi-variable analysis, both the unadjusted and the adjusted. And you can see here p-values were relatively unlikely to be seen. The only independent factor associated with an increased risk for fatty liver disease in this study was abdominal visceral adipose tissue. So BMI and higher abdominal visceral adipose tissue were both independently associated with an increased risk of fatty liver disease. And that gives us some room to evaluate our patient population and how we can avoid or have some modifiable risk factors for fatty liver disease. This is a theme that was presented across several different studies at CROI, and similarly, a very long-standing follow-up of people living with HIV in the Swiss HIV cohort was also evaluated. In this study, rather than abdominal CT scans, transient elastography was performed in 416 patients in the Swiss cohort. Different from the MAX, of course, is that this study included 27% women. There were an equal number of people around the same age and median CD4 count as the MAX study, and comorbidities also pre-existing in this population. And they found a 51% prevalence overall of hepatic steatosis, but specific to non-alcoholic fatty liver disease, a 43% prevalence. And again, significant risk factors in this cohort were BMI, in this case, greater than 25 kilograms, the being of European origin, and having been exposed to TAF, interestingly, and age over 50 were significantly associated with increased risk of both steatosis and non-alcoholic fatty liver disease. And lastly, the REPRIEVE cohort, most of you will recall, the REPRIEVE is a large clinical trial that's been ongoing for about 7 years now, evaluating the comparison of in people living with HIV at low risk for cardiovascular disease, pitavastatin versus placebo as an anti-inflammatory agent, and with the hypothesis being that that intervention would decrease the risk of atherosclerotic cardiovascular disease. So a subset of individuals in the REPRIEVE study, about 655 patients, underwent non-contrast CT scans through the course of the REPRIEVE follow-up, and were evaluated for overall for hepatic steatosis and specifically for the prevalence of non-alcoholic fatty liver disease. And they used different definitions here for steatosis related to NAFLD versus overall hepatic steatosis. And suffice it to say that the prevalence was substantial in the REPRIEVE cohort. About 27 or 21% overall had hepatic steatosis and 20% specifically non-alcoholic fatty liver disease. And again, BMI fell out, and a little, while not quite statistically significant, age fell out as independent risk factors, along with the metabolic syndrome for non-alcoholic fatty liver disease. And then lastly, looking at the impact of non-alcoholic fatty liver disease and non-alcoholic steatohepatitis, and I'll just digress for a moment to define NASH is along the spectrum of non-alcoholic fatty liver disease, but NASH having this specific component of inflammation and fibrosis in addition to just fatty infiltration. So this was a study done in people with HIV at 3 centers in Spain, followed for a median of 74 months. A little bit younger group than the other 2 studies I showed you, and a little bit lower median CD4 count, but also about 20% women. And this study attempted to look at the impact of NASH and non-alcoholic fatty liver disease on overall mortality in this cohort. And just overall, these are the causes of death for the 134 patients who died during the course of follow-up. But what you can see here, based on fibrosis categories with measurement of fibrosis throughout follow-up, it was the excess fibrosis, but not simple fatty liver disease, that was independently associated with mortality, suggesting that as people move along this spectrum from merely fatty infiltration to fatty infiltration plus inflammation and then to fibrosis, the risk of mortality increases in people living with HIV, independent of risk they may otherwise have with underlying HIV. And then the last study I want to highlight related to the REPRIEVE study and atherosclerotic cardiovascular disease was a prospective cohort analysis also done within REPRIEVE, and looking at this time CT angiography and immune phenotyping in a subset of men and women in REPRIEVE. And overall, the studies, what you can see, although it may be a little this may be a little bit small to see, but overall, the presence of coronary plaque was lower in women. And the yellow here is the presence of coronary plaque, and based on atherosclerotic cardiovascular disease risk. So those at the highest risk of atherosclerotic cardiovascular disease having higher rates of coronary plaque, but women better than men overall, regardless of the ASCVD risk score. When you looked at the presence of plaque with non-calcified portions or vulnerable plaque, which are those most likely to shear off and result in a cardiovascular event, again, women better than men, as you might imagine, and less in lower ASCVD risk scores than those at higher risk scores. So just cementing the fact that women do better than men with atherosclerotic risk and with the presence of plaques. And some of these key differences observed were related to some of the systemic immune activation parameters that occurred more highly in men than in women and may contribute to the overall risk of cardiovascular disease. The last study I'm going to highlight, just because I know several of you in the audience are highly interested in transgender women population. And again, relatively complicated study, which may be hard to go through. And I won't go through all of it, but it was an observational cross-sectional assessment of sex hormone concentrations, body composition, inflammatory markers in transgender women compared with cisgender men in the MAX. And these are the baseline characteristics of the two groups, the cisgender men and transgender women. The only differences being that the transgender women had lower fasting glucose levels than the men and lower levels of hyperlipidemia than the men. And more of the transgender women were on INSTI-based antiretroviral therapy than in the cisgender men. So not clear how much those baseline demographics impacted the overall outcomes. What you can see here in terms of body composition, interestingly, the transgender women had lower rates of intrathoracic fat, higher rates of thigh muscle fat, and lower rates of thoracic periaortic fat. So central fat lower in transgender women, but peripheral fat higher in transgender women. And these are the differences in hormone concentrations, most of which were statistically significant comparing transgender women with men. So more importantly, what are the implications of some of these comparisons? And this figure just attempted to look at the correlation between biomarker concentrations and body composition versus hormone composition or hormone concentrations. And I'll just summarize these data in the interest of time. Among older transgender women on feminizing hormone therapy, higher levels of estradiol and lower levels of testosterone were associated with worsening effects on both body composition and some of the select concentrations of cardiometabolic biomarkers. And greater visceral fat and fatty muscle infiltration, in addition to higher concentrations of endothelin-1 and NRAGE biomarker concentrations have been associated with increased cardiovascular disease. So transgender women on feminizing hormone therapy had higher fatty muscle infiltration, had higher levels of estradiol and testosterone, and some of the biomarkers of cardiovascular disease were higher in transgender women on feminizing hormone therapy. However, they also had higher adiponectin levels, which may offset some of the cardiovascular disease biomarker associated risk. So as I said, it was a complex study. The findings are complex. It's hard to know how they may impact future care of women, transgender women receiving feminizing hormone therapy, but I would encourage you to look at this poster. It may contain a lot more detail than I've been able to highlight here. So let me just finish by summarizing some take-home messages from a few of these studies. The first is that dolutegravir can be safely given with a variety of anti-TB treatment and prevention regimens that contain rifapentine given in various dose levels. Newer boosted protease inhibitors remain problematic and likely will not be usable in people being treated with rifampin or rifapentine containing regimens. Short course TB treatment regimens are now considered appropriate for many patients, and guidelines have recently been updated for these, for drug susceptible TB and for rifampin-resistant TB. Rapid testing and initiation of treatment for cryptococcal meningitis improves survival in people with HIV, and we have a new tool in rapid testing that may quantify the impact of immediate initiation of treatment. Rescue therapy with the 3-drug regimen of sofosbuvir, velpatasvir, and voxilaprevir for people with HIV who have failed DAA treatment for HCV is a safe and effective and comparable activity to that seen in people without HIV. And then screening HRA and proactive treatment for HSIL is effective in reducing the incidence of anal cancer in people with HIV. Non-alcoholic fatty liver disease and non-alcoholic steatohepatitis are associated with worse outcomes and potentially higher mortality rates in people with HIV, but also are associated with modifiable risk factors for each of these. And those may be a benefit to reducing the risk of NAFLD and its consequences. Higher rates of subclinical atherosclerosis based on plaque detection are more common in men compared to women with HIV, and may be related in part to variability in or increased biomarkers associated with immune activation and cardiovascular disease. And then lastly, transgender women may be at higher risk for atherosclerotic cardiovascular disease, in part due to some of the effects of feminizing hormone therapy. And I'll stop there. Thank you.
Well, Connie, my first question is, can you say, and I already lost the regimen, Vox,
yes,
10 times full, 10 times as fast as you can, full names.
yeah, right. Well, with I could probably get it right after about 3 more minutes, but we have 3 minutes left for questions, so let's do those instead. So
yeah, I think that
stop sharing, and I can look in the chat and see.
Yeah, so I mean, there were a few questions about the anchor study, and I also realized that I think Lalo's is not here today, but I think if you know, if you want to start answering some of the things, if you can, we then can have, you know, greater discussion with him, because I think those are most of the questions here.
Okay.
Yeah, so Nettie, oh, go ahead.
Yeah, so one point I do want to make in response to Nettie is, and this got a great deal of discussion during the abstract presentation at CROI as well, Nettie, is that how in the world in real life can you implement screening HRA for everybody? And I think that remains the crux of the argument here. Screening HRA obviously was extremely effective in picking up HSIL, and they did not present data on a comparison with screening HRA and anal cytology or anal pap smears. And that's going to be an ongoing question until we see those data presented from the study. And hopefully Lalo will have more data about that when he does his presentations. But I fully agree with you. I think translating this into clinical practice is going to be extremely complex. And even during the presentation, Joel Pileski commented on the fact that even training the people who were doing this in the course of the study to fully recognize and treat HSIL with screening HRA was complicated procedure. So I'm not sure how this can be implemented in clinical practice, and I think we need much more information. I do think it's critical, the point here, once you do identify HSIL, that active monitoring and waiting to see what will happen and whether they will reverse during follow-up is probably not going to be the appropriate approach in the future. And so once we sort out the best way to screen, once you do identify HSIL, immediate treatment, it should become the standard of care.
Connie, there's a question from Tom Martin, who I just said, come back. I don't know. I don't think they commented on this, but was there a number needed to screen for HRAs to prevent lung cancer? Do you know that information?
It was not in the presentation. I saw this presented initially at CROI and then again in a sort of longer presentation at a conference I was speaking in last week, and it was not mentioned nor asked about. So it may be in, obviously these are just the initial data from the first 30 patients, and there's a lot more data to come in the course of the analyses. So that may be one of the ones that will be included.
It's a very, very important question, obviously.
Yes.
All right, I stopped Tom from going to the hospital. Go.
Okay, go Tom.
And it's 9 o'clock also. I think if there are more questions, I'm sure that Connie would be happy to receive emails on a number of them if you can. But I really think, Connie, this was so comprehensive and so important that we always keep thinking about the other, aspects of HIV care that you, I think you really summarized some of the very important studies and highlighted new ones for me that I'm going to go look at more. So
yeah, and I would encourage people to look at the CROI website. A lot of what I selected were ones that I really thought would be pertinent to clinical practice. There's a lot more that were presented on other OI and organ system complications, but a little bit harder to translate into meaningful clinical practice pearls. So,
and that's why you're the best. So
I'm not the best, but thank you.
All right. Well,
all right. Well, have a great day, the rest of your day, everybody, and talk to you all later.
We will be doing cryptococcal meningitis next week. Rayhan Saeed, one of our fellows, is going to be talking about the CID New England Journal Medicine article that just came out and sort of where we are in cryptococcal meningitis treatment. So it should be really exciting.
Great.
Bye, everybody.
Bye.
Thanks, Connie.